Okay, so thanks very much for the introduction. I'm John Suderman. I'm one of the PGY residents here at UBC, for those of you who don't know me. I'm going to be speaking today about undescended testis in the post-pubertal patient. So a quick overview of today's presentation. I'll discuss cryptorchidism, its definition, and some epidemiology specific to the topic. I'll review some of the key features of testicular function as it relates to reproductive and endocrine function, along with malignancy risk in the cryptorchid male. We'll also quickly discuss the basis of the current CUA guidelines before moving on to discussing some of the literature updates and some of the intricacies involved in the evaluation and management of the post-pubertal cryptorchid male. So, as everyone here already knows, cryptorchidism is the failure of a testis to descend into a dependent scrotal position. It's one of the most common pediatric disorders of the male endocrine gland, and the most common genital disorder identified in male infants at birth, with 1 to 4% of full-term male infants and 30 to 45% of preterm newborn males being affected. We know that spontaneous descent is uncommon after birth, and if it is going to occur, it's most likely to happen within the first 6 months. And data regarding the incidence of undescended testicles in post-pubertal adults is limited, but the incidence is estimated to be somewhere between 0.8 and 2% based on some older cohort studies. Some authors have suggested that this number is higher in some immigrant populations, specifically those that have not had access to medical care during their developing years. Cryptorchidism can be categorized into 2 groups, both congenital and acquired. Congenital cryptorchidism means having an extrascrotal testis at the time of birth, while acquired means having a testis in the scrotum at birth, but having it later observed in an extrascrotal location. The peak age of diagnosis in acquired cryptorchidism is 5 to 7 years of age, with the majority of cases being unilateral, but up to 20 to 30% being bilateral. Cryptorchid testes can be found in a variety of locations, including the abdomen, inguinal canal, superficial inguinal pouch, the upper scrotum, and also in ectopic locations. Approximately 70% of cryptorchid testes have been shown to be palpable by a specialist. And of the non-palpable testes, 55% are intra-abdominal, 30% are in the inguinal scrotal region, and 15% are absent altogether. In general, treatment for an undescended testis aims to maintain a man's endocrine and reproductive function. I'll hopefully show how endocrine function is negatively affected by a delay in correcting or failure to correct the anatomic abnormality. I'll also hopefully show how the testis becomes more susceptible to progressive damage the longer the treatment is delayed. Reproductive decline is also evident in these patients. Nearly all men with uncorrected bilateral cryptorchidism develop azoospermia and subsequent infertility, while 50% of men with persistent unilateral undescended testis have a normal sperm concentration. Improvement in reproductive function with intervention has also been shown. In men who underwent childhood orchiopexy, 70% of men with a history of unilateral and about 30% of men with a history of bilateral cryptorchidism have a normal semen analysis. Interestingly, Coughlin showed that there's no significant difference in the time taken to conceive for men with treated unilateral cryptorchidism compared to men with no history of cryptorchidism. This curve shows the time to conception in males with unilateral and bilateral treated cryptorchidism compared to a control group with no history. There is a significant delay in the conception time in men with a history of treated bilateral cryptorchidism, with an average time to conception of 33.9 months. The average time to conception was 11 months in unilateral cryptorchid men and 8.8 months in the control group with no history of cryptorchidism. Overall paternity rates in men with corrected unilateral cryptorchidism reach approximately 90%, which is essentially a normal value compared to the general population. Men with corrected bilateral undescended testis have paternity rates around 65%. So why do we see this functional decline? In cryptorchid testicles, the number of germ cells decline rapidly over the first 3 years of life. A randomized control trial in Sweden showed that orchiopexy performed at 9 months resulted in increased catch-up testicular growth compared to orchiopexy at 36 months. This tells us that the timing of intervention is an important factor in testicular growth. The figure shown here displays a significant difference in the size ratio of the patient's undescended testis compared to their appropriately descended testis. The 9-month group shows less of a difference than the 36-month group. These findings were supported in studies out of Denmark and Korea. Structural evidence has also supported earlier orchiopexy. Biopsy in boys younger than 2 years have been shown to have significantly higher mean tubular fertility index scores, and this score represents the percentage of seminiferous tubules containing germ cells. There's also an increase in the total germ cell counts and lower interstitial fibrosis in younger boys compared with testicular biopsy after 2 years of age. Testicular biopsy at the time of orchiopexy showed a larger number of Sertoli cells at 9 months when compared to the 36-month group. There was also a significant reduction in germ cells in the 36-month group, up to 90%. Of note, different studies have investigated hormonal treatment in cryptorchid patients, this with the goal of promoting testicular growth and development. Treatment with either HCG or GnRH was found to stimulate testicular growth and initiate spermatogenesis in both patient populations. However, apoptosis of germ cells can be observed after cessation of hormonal treatment in a time-dependent manner. This cessation may permanently reduce the size of the testis once the patient reaches adulthood. And further, the efficacy in the literature is low and the results are inconsistent amongst the studies. Tajan reviewed testicular biopsies performed at the time of orchiopexy. 187 patients were studied, and they found that the patient's age at orchiopexy predicted germ cell depletion and Leydig cell loss. Compared to baseline rates in patients undergoing orchiopexy before 12 months, germ cell depletion was worse for those undergoing orchiopexy at 13 to 24 months with an odds ratio of 3.9. The odds ratio was even higher in patients undergoing orchiopexy at 25 to 96 months at 8.3. And then the patients undergoing orchiopexy past 96 months had the highest odds ratio at 16.8. The odds of having Leydig cells present in the biopsy were also the lowest for the oldest group. Tajan also studied histological changes seen in testes with delayed cryptorchidism treatment. Findings included basement membrane thickening, decreased diameter and atrophy of seminiferous tubules, hyperplasia of Sertoli cells, and abnormal hyperplasia of the remaining Leydig cells. The photo A in the top left shows a normal testicular biopsy with normal number of germ cells, which are the black arrows, Leydig cells, which are the arrowheads, and Sertoli cells, which are the white arrows. Photo B in the top right shows mild fibrosis with absent Leydig cells. Photo C in the bottom left shows moderate to severe fibrosis with no germ cells. And photo D shows no fibrosis, but also no presence of germ cells or Leydig cells. Cryptorchidism is obviously a well-established risk factor for testicular malignancy. Approximately 5 to 11% of testicular cancer incidence is attributable to cryptorchidism. A meta-analysis of 21 case control studies was completed by Diekman and Pickelmeyer, looking at the epidemiology of germ cell tumors. This study showed an increased odds ratio for developing testicular cancer in patients with a history of cryptorchidism ranging from 3.5 to 17, with an overall relative risk of 4.8. The pathogenesis of malignant transformation in these patients has not yet been fully defined, but models have suggested that the first step involves developmental arrest of primordial germ cells, or gonocytes, which are these guys over here. These cells have been found to exhibit similar phenotypic features to carcinoma in situ cells. These arrested cells undergo malignant transformation, and tumors then develop in young adults once CIS cells begin to proliferate rapidly with the onset of puberty. With these physiologic changes in mind, along with some of the other common issues associated with a cryptorchid patient, the goals of therapy outlined in the CUA guidelines include maximizing the chance of adequate hormone production and fertility potential, minimizing parental anxiety and malignancy risk, treating associated conditions such as inguinal hernias, preventing testicular torsion, locating the testis into a position amenable for self-examination, and also maximizing the psychological benefit in restoring the patient's normal anatomy. Prepubertal cryptorchidism guidelines are generally quite clear and consistent amongst the differing professional bodies, including the AUA, CUA, and EAU. They recommend evaluation by a specialist by 6 months of age and then orchiopexy before age 18 months. Boys with acquired cryptorchidism after 6 months should be referred promptly to a surgical specialist. And hormone therapy has a limited role in the management of cryptorchidism and should not be recommended as first line. Of note, the AUA guidelines state that in the presence of a normal contralateral testis, orchiectomy may be performed if the testicular vessels and vas are short, if there's a dysmorphic or hypoplastic testis, or if the patient is post-pubertal. This recommendation is listed as a clinical principle due to lack of evidence to support it. The CUA guidelines also state that orchiectomy should be an option if unilateral intra-abdominal or inguinal hypertrophic testes are identified after puberty. But how is this patient population different than the pediatric population, and what should clinicians be aware of when counseling patients who have post-pubertal cryptorchid testes? This largely forms what I'm going to talk about for the rest of the presentation. So if changes in testicular function and physiology guide our treatment recommendations, understanding normal testicular development during puberty basically becomes imperative. Until recently, little was understood about cellular and structural changes in the testicle over the course of puberty. Guo and his team formed a transcriptional cell atlas of the developing human testis during puberty. They characterized the pubertal process by profiling transcriptomes of approximately 10,000 testicular cells from boys aged 7, 11, 13, and 14. These specimens span puberty and were compared to samples from infants and adults. Previous models suggested that there was a first wave of spermatogenesis during male infancy. This wave was thought to initiate self-renewing sperm as early as 2 to 3 weeks after birth. Guo found, however, that humans lack this first wave and maintain sperm in an undifferentiated state prior to puberty. We know that male puberty typically begins between 10 and 13 years. Guo saw that only a small amount of incomplete spermatogenesis is present in parts of the juvenile testis prior to puberty, and mature sperm aren't usually present prior to age 10 or 11. Meiotic cells, which are the cells that eventually become mature sperm, typically undergo cell death and apoptosis during the peripubertal phase. Specifically, this is seen after infancy, but prior to full sexual maturity. Structurally, prepubertal testes have undifferentiated sperm embedded in small cords of Sertoli cells. These cords lack a defined lumen. During puberty, the basal lamina develops to form structured seminiferous tubules, and this leads to coordinated development of myoid cells, Leydig cells, and Sertoli cells. These in turn contribute to hormone signaling, and together these cells combine to form the main testicular niche. Guo's histological samples showed major changes in testicular morphology over puberty. This is seen in the figure on the left. In the 7-year-old sample, there were small testis cords lacking a structural lumen. The tubular structure became more apparent in the 11-year-old sample, and a clearly defined lumen was observed across the tubules of the 13 and 14-year-olds. Guo also found that germ cells from both the 1 and 7-year-old specimens had only undifferentiated sperm, seen in the second figure. In the 11-year-old sample, there's still a high proportion of sperm cells in their early state, but differentiating sperm and meiotic cells began to emerge. In the infant and 7-year-old samples, sperm was rare at 3 to 4%, whereas in the 11-year-old, sperm increased to 10 to 15%. They did note that post-meiotic cells increased in the 13-year-old, indicating more of a commitment to cell meiosis. And then in the 14-year-old sample, this resembled the adult, indicating full spermatogenesis. All of that taken together, Guo's data points to 3 separate phases in testicular development between infancy and puberty. The first is a phase where undifferentiated sperm are dormant or are slowly self-renewing. The second represents a transient period of sperm proliferation with limited and incomplete spermatogonial differentiation. That occurs early in puberty. This transitions to the third, which includes the establishment of steady and balanced spermatogonial self-renewal and differentiation alongside commitment to full gametogenesis. Guo explored Sertoli cell development during puberty as well. In the 7-year-old samples, they found immature cord structures made of sperm and Sertoli cells. The sperm are shown by the UTF1 marker, and the Sertoli cells are shown by the SOX9 marker. When puberty starts, Sertoli cells and sperm align at the basement membrane of the tubules, and we see a lumen begin to form. This is seen on the 11 and 13-year-old samples and continues in the 14-year-old sample. We know that the prepubertal testis has a pool of undifferentiated germline stem cells, and that these cells live in the immature niche. In early puberty, the niche matures first, which helps define the structure of the seminiferous tubule. This structure promotes hormone signaling and in conjunction with the hypothalamic pituitary axis. Only after these structural changes occur do we see proliferation of undifferentiated sperm, and this is followed by spermatogonial differentiation and generation of the first meiotic cells, ultimately leading to steady generation of spermatids and mature sperm. The point is that without proper seminiferous tubule architectural formation, there is impaired spermatogenesis. I showed that figure earlier on, which showed histological biopsy images from cryptorchid patients. Findings from this study included decreased diameter and atrophy of seminiferous tubules, along with hyperplasia of Sertoli cells and Leydig cells. These are examples of abnormal niche development in the undescended testis, and we now know that these structural abnormalities make it difficult for a man to achieve normal spermatogenesis. These abnormalities may also become less likely to correct themselves the longer the testicle remains cryptorchid. So progressive decline in testicular function during and after puberty has been shown in multiple retrospective reviews of orchiectomy specimens. Ryang and his team analyzed 31 specimens from unilateral cryptorchid testes in post-pubertal men. They assessed for spermatogenesis and cancer, Out of these 31, 27 had impaired spermatogenesis, 12 had no germ cells present whatsoever, and 1 had evidence of intratubular germ cell neoplasia. Rogers and his team studied 52 patients with post-pubertal cryptorchidism. These patients ranged from 15 to 66 years of age with a mean of 26. Among the 52 specimens, 31% had germ cells present and 69% had a complete absence of germ cells in the seminiferous tubules. There was only 1 patient with mature sperm out of the 52. And this patient first presented with a palpable testis in the superficial inguinal pouch. Specimens with arrest at a higher location were more likely to lack spermatogenesis. These locations included the inguinal canal or within the abdomen or pelvis. With regard to malignancy, only 1 of the 52 was found to have testicular CIS on path. Roy Hyam and his team looked at reproductive hormone levels and semen analysis from men with previously treated undescended testes. They compared them to normal testes at birth from patients with normal semen analysis. Men with previously treated undescended testes had significantly higher FSH levels than the controls. They also had sperm concentrations that were significantly lower. The lowest mean sperm concentrations were in patients with the bilateral undescended testis. 21% of men had normal sperm concentrations despite having previously undescended testes. Oligospermia was diagnosed in 44% of men, and azoospermia was detected in 35%. This relationship was further explored by Roy Hyam in a later paper when his team found that the age at surgical correction was inversely correlated with testicular volume and semen sperm concentrations. The age at correction was also positively correlated with FSH levels and LH levels. Even when all the patients with an age over 14 at the time of correction were excluded, the correlations were still significant. Of note, the mean age at correction was lower in the normospermic cohort compared to the azoospermic cohort. There were some men with azoospermia and low serum testosterone despite early correction. Likewise, there were some normozoospermia patients with normal testosterone levels despite late correction. Malignancy findings have mostly been observational. Walsh put together a meta-analysis of 5 studies investigating whether cryptorchidism was associated with increased risk of testicular cancer, specifically whether age at orchiopexy changes this risk. They found that testicular neoplasm was 1.6 to 7.5 times more likely in men with a history of cryptorchidism. There was an increased risk in all 5 studies if orchiopexy was delayed or not performed. And using an age cutoff of 10 to 11 years for orchiopexy, the odds of malignancy were 2.9 to 32 times greater for those who had not yet had an orchiopexy compared to those who had. Combining all of these studies, the testicular cancer was 3.4 times more likely in men where orchiopexy was delayed or not performed. This in the meta-analysis was not statistically significant, but there was noted to be a limited number of patients included in the studies. So the statistical power wasn't very high. So what should be evaluated in the post-pubertal cryptorchid patient? In both pediatric and post-pubertal patients, physical exam is the cornerstone in the clinical evaluation. Findings on our exam is what guide our next steps in managing the patient. There's previously been some debate as to whether or not imaging should be included in workup. As I mentioned previously, data suggests that more than 70% of undescended testes will be palpable by a specialist. So imaging is obviously not needed to locate these testes in the majority of cases. Patients with concern for testicular mass on exam should undergo malignancy evaluation, which is different prior to surgical management. This obviously includes imaging along with serum tumor markers. But what about imaging for workup in the non-palpable cryptorchid testis? There's a theoretical role for imaging in this situation, and it would ideally be able to locate and identify testes for intervention. According to the AUA, ultrasound is the most common imaging modality ordered by care providers. Ultrasound is only 45% sensitive and 78% specific for localizing non-palpable testes. Looking at Tasian's nomogram from 2011, the pretest probability that a non-palpable testis is within the abdomen is 55%. Using the positive likelihood ratio and upper confidence interval, which are the solid and dashed red lines, an ultrasound that identifies a non-palpable testis within the abdomen increases the probability that the testis is indeed in the abdomen to 64% and 83% respectively. Using the negative likelihood ratio and lower confidence interval, which are the solid blue and dashed blue lines, an ultrasound that does not identify a non-palpable testis decreases the probability that the testis is truly in the abdomen to 49% and 36%. Obviously, these numbers pose a clinical issue, as choosing not to operate on a patient based on ultrasound findings increases the risk that a testis is left in the abdomen, and this carries with it an elevated risk of developing testicular malignancy. Further, this patient would be at a higher risk for presenting with advanced disease due to their inability to perform self-examination or be examined by a clinician. Ultrasound should therefore not be used to inform management or eliminate the need for surgical intervention. Superficially, MR does seem to be a more attractive option. It's more accurate than ultrasound and doesn't expose a patient to any ionizing radiation like CT scan. Young evaluated 21 boys who were aged 1 to 10 for a total of 23 non-palpable testes. Gadolinium-enhanced MR angiography correctly identified 4 intra-abdominal, 10 intracanalicular, and 8 canalicular vanishing testes. It did, however, fail to make the diagnosis in one patient with an intra-abdominal vanishing testis. Laparoscopy and surgical exploration were then performed, and the MRA was found to have a diagnostic sensitivity of 96% and a specificity of 100% for localizing non-palpable undescended testes. However, even with the use of this contrast, the absence of testis on imaging does not exclude its presence on exploration. Conventional MR studies are not overly sensitive and are unable to provide a reliable screening tool for non-palpable testes. Approximately 40% of non-palpable testes are atrophic and vanishing and may not be picked up on conventional MR. Young found that the sensitivity of MR for diagnosing non-palpable testis was only 39% and 25% for intra-abdominal and 0% for vanished testes. Therefore, these imaging techniques have a limited role in terms of localizing undescended testes. Krishnaswamy looked at 8 observational studies in a meta-analysis exploring conventional MRI used to identify the presence or absence of testicles. There was notably a false positive rate of 14%, with the most common error being mistaking lymph nodes for testicular tissue. Conventional MR was further found to have a false negative rate of 38% of viable intra-abdominal testes. Essentially, this means that more than a third of viable testes may be missed. Kuchiria studied laparoscopic exam in 10 cryptorchid adult patients with a mean age of 29 years. Consistent with the findings in younger pediatric patients, ultrasound was accurate in locating the testes in 38% of cases. MRI was accurate in 66%, and laparoscopy was accurate in 100% of the cases. Obviously, this study is limited by its observational nature and low enrollment, but its results are consistent with the numbers presented in the pediatric studies. This seems to make it reasonable to extrapolate the previous study's results to adult patients. So given the possibility of a retained testis containing malignancy, it's difficult to justify not doing a diagnostic laparoscopy based on imaging findings. Performing an MR or ultrasound preoperatively is unnecessary, as it just increases treatment costs and does not change our management. Therefore, the AUA and EAU recommend that providers not perform imaging in the assessment of patients with cryptorchidism before referral to a surgeon. The CUA guidelines specifically state that imaging in cryptorchidism is not cost-effective, may delay treatment, and is not recommended in preoperative assessment in the cryptorchid patient. Diagnostic laparoscopy is certainly considered the gold standard for localizing non-palpable testes. Laparoscopy provides the additional benefit of definitive treatment at the time of diagnosis, and this further increases its utility. Having said that, there may be some instances when the use of imaging can be justified in these patients. Some have suggested using imaging to rule out malignancy in non-palpable cryptorchid testis, specifically in those patients under surveillance who are being observed rather than being treated surgically. This includes those presenting with undescended testis for the first time as adults, where laparoscopy is not feasible and observation is preferred. As I discussed earlier in the presentation, decline in fertility begins as early as 18 months, with decline continuing as long as the testis remains cryptorchid. Management in older patients has therefore primarily focused on mitigating cancer-associated mortality risk instead of fertility preservation. Because of this, orchiectomy has historically been the recommended treatment for post-pubertal cryptorchid patients. In an old 1975 study, Martin and Menck found that the surgical risk outweighs the cancer mortality risk in patients over the age of 50. Obviously, this is quite an old study, and perioperative mortality has decreased since that time due to improvements in perioperative care, and also due to the discovery of platinum-based chemotherapy regimens for treating testicular malignancy. So this clinical scenario was re-examined by Shaw et al. In 2019, using updated germ cell mortality data, comparing it to updated perioperative mortality data based on ASA classification levels. You can see in the table that the lifetime risk of dying from a germ cell tumor decreases with increasing age. Perioperative mortality exceeded the risk of death from a germ cell tumor for men aged 50.2 for ASA class 1, which are healthy patients, and age 35.4 for ASA class 2, which are patients with mild to moderate systemic disease, but these diseases are well controlled medically. Men with an ASA class higher than 2 were found to have a higher risk of perioperative mortality compared to germ cell tumors for all ages. Shaw recommended that prophylactic orchiectomy should be advised in ASA1 males younger than 50 years old and ASA2 males younger than 35 years old. The study also found that the risk of perioperative mortality for ASA3 or greater patients outweighed the risk of death from testicular malignancy at all ages, and they recommended observation in these patients. The CUA guidelines from 2 years prior to that study in 2017 recommend that orchiectomy should be considered for hypertrophic or atrophic undescended testes up to the age of 50, and observation is likely appropriate thereafter. This is largely based on the finding that testicular malignancy is exceedingly rare in men over the age of 50. Despite the known ongoing fertility decline in cryptorchid testes, there is some evidence that suggests younger post-pubertal men may benefit from testicular preservation to maintain their fertility. Coney in 2014 evaluated orchiectomy specimens in 51 men with unilateral undescended testis, aged 20 to 24 at the time of military recruitment. Approximately half of the patients had germ cells present at different maturation levels. Other changes were also found consistent with what I presented earlier, including basal membrane thickening, decreased seminiferous tubule diameter, Leydig cell hyperplasia, and there was a single case of intratubular germ cell neoplasia. The presence of germ cells obviously does not guarantee paternity, but clinical discussion around testicular preservation could be considered depending on the patient's goals, especially with recent improvements in assisted reproductive technologies. So if a man is highly motivated to evaluate his fertility potential prior to orchiectomy, initial workup generally starts with 2 sets of semen analyses, with the results guiding further evaluation and management. Generally, a concentration of less than 5 million sperm per milliliter would warrant further investigation. Otherwise, physical exams should include general appearance, specifically looking for any syndromic features, gynecomastia, obesity, virilization, palpation of the bilateral vas, testicular volume, texture, evaluation for varicocele, circumcision status, and evaluation of the meatus. In cryptorchid patients, the goal would be to rule out other structural causes such as vas deferens integrity. If semen analysis is abnormal, you can also consider sending hormonal and genetic testing. Hormone testing would include AM testosterone and FSH, with LH, prolactin, and estradiol being potential adjunct investigations. Genetic testing might include karyotype and evaluation for a Y chromosome microdeletion, with 47XXY being the most common finding on karyotype. Most commonly in cryptorchid patients, we see a high FSH and LH, which correlates to dysfunctional Sertoli cells and Leydig cells respectively, and indicates testicular azoospermia. Abnormal findings with any of this workup may warrant a referral to an andrologist prior to surgical intervention. An andrologist might be able to offer additional surgical intervention at the time of either orchiopexy or orchiectomy. The likelihood of finding adequate sperm, even for assisted reproductive techniques, is low, especially in cases of intra-abdominal testes. Multiple options for extracting sperm in the general azoospermic man exist. These options include epididymal retrieval as well as testicular retrieval. Epididymal retrieval is not considered an option for these men, as sperm are unlikely to be found in the epididymis, given they have a testicular source of azoospermia. Testicular sperm retrieval would then be the option of choice, with microdissection or M-TESI being the most effective method. This technique involves dissecting out individual seminiferous tubules and allows for microscopic examination of the seminiferous tubules to assess for heterogeneity. The goal being to identify the tubules that are more likely to contain mature sperm. This technique is better than random biopsy or aspiration and exposes the testicle to only minimal damage. A limitation to this technique is that it can only be performed at centers where intracytoplasmic sperm injection is available, as these centers are used to appropriately handling the sperm samples if they are required. This technique shows a pregnancy rate with a median success around 18 to 20% with successful testicular sperm extraction. So in conclusion, cryptorchidism is best treated before 18 months of age, but can present later in life. The clinician should remember that physical exam rather than imaging or labs is the cornerstone of diagnosis. Post-pubertal patients should be counseled that uncorrected undescended testis are likely to have minimal fertility potential and also an increased malignancy risk. But there are some cases where observation rather than surgical management may be the best treatment choice, especially in older comorbid patients. And finally, fertility options do exist, but the success rates remain low in post-pubertal cryptorchid patients. I'd like to give a special thanks to Dr. Ryan Flanagan for reviewing these slides with me. Here are some references, and then open up the floor to any questions.